and he will deliver a lecture on ECG abnormalities and hypertrophic cardiomyopathy. As protocol, before starting of the lecture, I'd like to request Professor Atahar Ali sir to say some words regarding our very own Azizul Hoque sir, and then we proceed for the lecture. Atahar Ali sir.
Thank you, Tushar. Good evening and good night to everybody. This is a very nice time. আমি অলওয়েজ আজিজুল হক ভাইয়ের লেকচার খুবই এনজয় করি এবং আজিজুলের লেকচারগুলো এত চমৎকার হয় যে মানে এটা সবসময় আমার প্র্যাকটিক্যাল লাইফে খুবই কাজে লাগে। আজকের টপিকটা খুবই ইন্টারেস্টিং এবং এটা মানে আমরা এতদিন ধরে এত গোছানো কোনো টপিকস দেখে নেই যে ইসিজি অ্যাবনর্মালিটিস হাইপারট্রফিক কাজের মাধ্যমে। হোপফুলি এটা একটা খুবই একটা ইম্পর্টেন্ট এবং ইন্টারেস্টিং সেশন হবে। আমি আজিজুল ভাইকে লেকচার দেওয়ার জন্য রিকোয়েস্ট করছি। আজিজুল হক ভাইকে পরিচয় করে দেওয়ার কিছু নেই, উনি রিনাউন্ড কার্ডিওলজিস্ট এবং সবচেয়ে ভালো হচ্ছে উনি একজন এক্সেলেন্ট প্রেজেন্টার এবং টিচার। আমাদের অলরেডি ফোরামে হি ইজ ভেরি মাচ পপুলার। আমি আশা করি আমরা সবাই তার লেকচারটা এনজয় করবো। আজিজুল হক ভাই, থ্যাংক ইউ ভেরি মাচ ফর ইউর
Thank you very much for the kind introduction. Assalamu alaikum everybody. আজকে যে টপিকটা আমরা ডিসকাস করব যে ECG abnormality and hypertrophic cardiomyopathy, and it's an important topic. It's one of the most common genetic disorders that we know, genetic cardiovascular disorders that we know, and a lot of time we miss it. Interesting to note that like every one we diagnosed 2 hypertrophic cardiomyopathy patients we miss, despite that what we have advanced nowadays with our clinical expertise and imaging technologies. So I have nothing to disclose. So our learning objectives to just be familiar with some specific patterns of ECG abnormalities in hypertrophic cardiomyopathy, or we call it HCM. And nowadays we're getting more and more data of artificial intelligence on ECG and echo findings incorporation that better help us to diagnose HCM. And very important that I'm going to show a few cases and data that important rule out other causes of LVOT obstruction because their treatment is different. And always make sure that you focus on provocative studies to elicit the diagnosis of obstructive HCM. And there's new data coming out and also some trials already finished, and we're using a novel therapy right now, cardiac myosin inhibitor, in the treatment of HCM. And definitely, most importantly, emphasize longitudinal follow-up of these asymptomatic patients of hypertrophic cardiomyopathy, because with our data right now, we see that 25% of patients with asymptomatic hypertrophic cardiomyopathy would turn in, result in obstructive HCM. So let's look at the case first. And a 48-year-old male with a history of hypertension, cholesterol, presents to the emergency department with chest pain, blood pressure 144/84, heart rate 76, and ECG as follows. Anybody from the audience, our trainees, can comment on the ECG if you're volunteers there. Anybody, please? All right. If anybody want to comment on the ECG, these patients came to the emergency room with chest pain. There is abnormality on the ECG. We see some T-wave inversion, definitely, as we see like anterolateral T-wave inversion and some T-wave inversion in inferior leads, and coming with chest pain. Okay, so let's go to the next slide. What's the next step is going to be with the patient? Let's have a poll. And please, participants, participate in the polls. What's the next step is going to be? So with this significant ECG change, would they take the patient to the cath lab because he's having chest pain, and send him for non-invasive cardiac stress testing, or just get some serial troponin and get an emergent echo soon as possible, or just optimize blood pressure since blood pressure will be on the high side, since findings are consistent with hypertensive heart disease, some LVH there, and maybe non-specific repolarization abnormality there, and you can discharge the patient home. Let's have a poll on this patient.
Amrul bhai, make a poll and keep the poll for 20 seconds.
Actually, we have good information, like 57% of the patient, they are asking about get serial troponins and echo. That would be probably most likely, the next step, because yes, look at that, the pattern of EKG is a deep TO inversion. Definitely, you need to make sure it's not ischemic. That is true, okay? But the pattern is a little bit different, like deep TO inversion, and at least you need to have serial troponin, and echocardiogram will tell you the patient is having acute wall motion abnormality or not before you take him to the cath lab. Okay, it's not STEMI that emergently you need to take him to the cath lab. The second question we have.
Sir, can I interrupt for a second?
Yes.
If we look at the ECG closely, that V3 and not V2, but V3, there is biphasic T-wave pattern, which may sometimes confuse with Wellens pattern. So whether at all, we have to think in that line also, because a young man with intermittent chest pain with this type of ECG work, which might not be abnormal on echo.
That is absolutely correct. And normally we also see V2, V3 level TO inversion. V2 is not involved here, more like anterolateral, but absolutely right. If the patient had chest pain coming with the ECG, they have biphasic TO changes like V2, V3, and V1, V2 lead and V3 lead. The Wellens syndrome you cannot rule out, but his V2 is still okay, but V3 is very mild. But deep TO inversion, Wellens syndrome, we normally do not see like anterolateral TO inversion, but definitely a very point is well taken. If you see like biphasic T wave, despite that they're not having chest pain at this moment when you examine the patient, but had history of chest pain probably half an hour ago or an hour ago, you have to make sure they rule out Wellens syndrome. So, and we did his serial troponin, they're negative, and the echocardiogram shows no all motion abnormality, biventricular normal function, and no asymmetric septal hypertrophy. And unfortunately, we had cardiac CCTA in the emergency room. We did cardiac CCTA. It demonstrated no significant coronary artery disease. So what we're going to do at this level, okay, you're planning to, yes, the patient is not having likely acute coronary syndrome, no significant coronary artery disease ruled out. But with that ECG, you cannot just let him go home with just blood pressure management, because you're already concerned the significant T-wave abnormality and anterolateral leads is deep T-wave inversion. So you need to keep in mind whether the patient does not have any another pathology, particularly some variant of hypertrophic cardiomyopathy. This patient should be followed up with cardiac imaging, and if you have availability of MRI, cardiac MRI would be appropriate choice to do. You can do it as an outpatient if it's not available right now, and it's not necessary to do it right then. Patient can go home and schedule him for outpatient cardiac MRI. And as you see that cardiac MRI, there's some apical thickening of the heart muscles, and also you see a spade shape like ventricular contraction, a spade shape. Very apex is very kind of tipped way. We call it spade shaped ventricle. Okay, but normally in normal condition, when in normal heart, when there's thickening in systole, we expect also like apical area will be less thickened than slow tapering of the apical area, less thickened rather than other area. But here we see the thickening still remains. That means there's significant hypertrophy there. That's kind of one of the hallmark for apical variant of HCM. But if you look at that dimension here is 10 millimeter, that's 1 centimeter. Normally by guidelines criteria, we expect like 15 millimeter, but this is relative. We call this type of variant of apical hypertrophic cardiomyopathy, we call it relative apical hypertrophic cardiomyopathy variant. And we did a gadolinium enhancement. We don't see much gadolinium enhancement in that area. So it's fairly, The concern is that the patient had some chest pain, intermittent chest pain that came with. We ruled out coronary anatomy, abnormal coronary anatomy. Patient's coronary is, no significant blockage, that's fair to say. And the patient having chest pain, what's the mechanism of chest pain? Still, we haven't determined. But we know that in apical hypertrophic cardiomyopathy or any kind of hypertrophic cardiomyopathy, they have a lot of muscles, significant hypertrophy and disarray of the muscle distribution. And normally we have apical coronary arteries, then with branch vessel, it goes in, perforators goes in and supplies the myocardium. But what happens in hypertrophic cardiomyopathy, significant left ventricular hypertrophy, that the coronary artery, they can go inside the muscle. And also imagine one thing, that for example, you have 100 grams of tissue, you have one vessel down there, one vessel for 100 grams of tissue. If that mass grows to 300 grams of tissue and single vessel, you know that you will not having enough blood supply. There will be demand-supply mismatch because amount of tissue is much higher than the amount of blood flow there. That's called relative ischemia. If the patient having some walking, heart rate goes up, the patient could be symptomatic with chest pain. That's probably the mechanism of chest pain on this particular patient who came to the emergency room with this ECG. All right, let's look at some variants of ECG that we see in hypertrophic cardiomyopathy. This particular variant, just focus on that. As we see, like dagger-shaped Q waves, small Q, but in lateral leads, and also sometimes it would be inferior leads, dagger-shaped, very sharp dagger-shaped Q waves. And most importantly, they're different from ischemic Q waves, like from MI, that this duration of the Q wave is less than 40 milliseconds, smaller dagger shaped. When you see this type of variant and significant LVH, there could be some repolarization abnormality also. The ST does tube changes in this type of patients. But you need to be alerted whether this variant is more common in asymmetric septal hypertrophy variant, like dagger-shaped, small, deep Q waves, okay? Not necessarily they have to be in inferior leads, but definitely they will be in lateral leads. Let's look at another ECG. Like in this particular ECG, we see some dagger-shaped Q waves. We call it septal Q waves. Normally, septal Q waves we see in, they're sharp, less than 40 milliseconds and significant LVH. If you see that, you still keep in mind that could be a presentation of asymmetric septal HCM variant. And this type of patients sometimes have associated short peer interval, and sometimes they are associated, not like a small number, could be WPW syndrome also associated with that. So the second group of a pattern of the ECG changes in HCM that we saw in the first patient that we showed you, significant deep T wave inversion in lateral leads or anterolateral leads, and one AVL. Sometimes you can see also inferior leads, but not necessarily they have to be, but anterolateral leads, they're always there. With this variant, if you see that, it's kind of looking like cerebral T waves like picture. But if you see that significant LVH and that type of T wave inversion deep, always think about it could be also presentation of apical variant of HCM. And this type of patients, if they come with syncope, chest pain, you cannot, even echocardiogram looks normal, superficially. You need to do further imaging modality, including MRI, to rule out whether the patient has apical variant of HCM. As I see here,
Sir,
yeah, go ahead.
if in presence of this type of ECG with that much T wave inversion, is it possible to have normal echocardiography or normal thickness in echocardiography? Is it possible?
Yes, it can. Actually, a lot of time we miss it, the apical hypertrophy, but just the way we look at the echo. And yes, it is possible to have some normal thickness, like 10 millimeter thickness. Normally, we don't call it hypertrophy. But as I mentioned to you, you need to have either contrast echo or cardiac MRI to see when they contract the ventricle, if you see a spade-shaped ventricle, that lack of tapering of the thickness in systole at the apex, that's one of the hallmark of apical hypertrophic cardiomyopathy. Despite that, their thickness could be 10 millimeter. That we called earlier, that could be, we called relative apical hypertrophic cardiomyopathy, because these type of patients definitely will develop more apical hypertrophy in the future, and you need to keep in mind to follow these patients longitudinal basis. And if the patient comes with symptoms like syncope, chest pain, you cannot rule it out just looking at the echo. You probably have to do cardiac MRI to see that, or contrast echo. Sometimes you see in contraction, you see like a spade-shaped ventricle at the very apex. You see lack of tapering of the thickness of the ventricle there. It will be still thickened in the apex. Normally, we expect it lower thickness in the apical area with systole in normal echo. But here, lack of thickness, lack of tapering of the thickness is diagnostic. Yes, you need to do either contrast echo or cardiac MRI. And as I mentioned to you, this ECG change that we told you, that could be also in anterolateral part. Okay, not much. We saw V5, V6. We saw the previous ECG is more dominant, but it could be also, anterolateral part to inversion and one in AVL. So when you see this type of ECG, always think about in your hindsight patient, whether the patient has HCM, okay? And they need further imaging modality to confirm the diagnosis if echo is non-diagnostic. So we talked about that. As I see here, what I'm talking about, like lack of apical tapering in systole. So let's look at that. You look at that spade-shaped ventricle here in this view also, spade-shaped ventricle, very tapering ventricle, very thick apical area. Because normally you expect in normal cardiac muscles, this area will be more or less thickened in systole in normal myocardium because apex is thinner area than other areas. But here, thicker area is lack of tapering, but still stays thickened. Despite that, it's a systole. And also, a look at how the ventricle shape look like is called in a spade-shaped ventricle. It's like a spade card, okay? Spade-shaped ventricle. This is very diagnostic of apical hypertrophic cardiomyopathy. And the patient needs to be, this type of patients we refer to hypertrophic cardiomyopathy clinic for longitudinal follow-up. Extremely important. Despite the patient might be asymptomatic, 25% of this type of patients will end up symptomatic in the long run, and their event rate is also significant if they become symptomatic. So if we classify HCM, there's three clinical groups that we call non-obstructive. That means if LVOT gradient is less than 30 millimeter mercury. Obstructive, we see 30 or more millimeter mercury gradient in between the LVOT and aortic valve, the gradient that we talk about. And we call latent obstructive. Latent obstructive means, and resting condition, they don't have obstruction. They have less than 30 millimeter mercury gradient. But when you provoke the patient with some testing like Valsalva, and also exercise treadmill or bike exercise, amyl nitrate, you can elicit this higher gradient. We call provocation-induced higher gradient. We call latent obstructive. This kind of clinical diagnosis, non-obstructive, obstructive, and latent obstructive. If you look at the epidemiology of that, the prevalence of LV outflow obstruction, as I mentioned, defined by 30 or more millimeter gradient across the LVOT and aortic valve, 30% is non-obstructive. But as I mentioned, resting condition without provocation, we get another 37%. But if we provoke this patient, we get another 33 patients. What is bottom line? Bottom line is that this group, these patients, like two-thirds of these patients with hypertrophic cardiomyopathy will have obstruction, 37 plus 33. This part is after provocation. So extremely important to do provocation and to train the echocardiographic technician in your office how to do the provocative test. Because if you see any increase in gradient on the LVOT area or mid-cavity area, they have to put the Doppler probe from the apex and slowly go down to mid-cavity area and go to the LVOT area. If anywhere you see increase in gradient normal than 1 millimeter per second, velocity. And we always we always advise them, and it's in Emory, it's compulsory to do the Valsalva. And they need to be trained how to do the Valsalva, because it can provoke a lot of patients with higher obstruction with provocation. So don't miss those patients. As you see, this data came from Cleveland Clinic. This is one of the largest center, because in US, the Mayo Clinic and Cleveland Clinic, and also we do in Emory, is also a hypertrophic cardiovascular center now. So they have a lot of database. They followed like asymptomatic hypertrophic cardiomyopathic patient. Interesting enough, asymptomatic HCM is not benign. Okay, they studied 3,393 asymptomatic hypertrophic cardiomyopathic patients baseline, and 39% were classified as obstructive cardiomyopathy, and 61% was non-obstructive hypertrophic cardiomyopathy. And look at that, the curve, the blue line is obstructive cardiomyopathy. So their event rate, mortality rate was higher than the non-obstructive asymptomatic that was close to baseline with other population. But if they become obstructive or symptomatic, definitely their prognosis is not worse, basically. So you do not want to miss those population. And as I mentioned to you, with these asymptomatic patients, about 25% of these patients will convert to symptomatic HCM over their course of disease. As I see there, we talked about epidemiology, definitely 1 in 500, but in some studies, 1 in 200 is a very common genetic disorder, cardiovascular disorder. In the population, you'll find out 1 in 500 will have HCM. And interestingly enough, that every one diagnosis, we miss 2 diagnoses of HCM. So you need to be very careful. Like, keep in mind that you're not missing any HCM diagnosis, okay? And we know that it's a genetic disorder. Most common gene, MYBPC3, 45%, is a myosin binding protein abnormality, and heavy chain abnormality is MYHC gene, 35%. But they have very well penetration expression that will get different phenotype on that, okay? But as I mentioned to you, there's all the hypertrophic cardiomyopathy patient, the 2/3 of them will have obstruction, okay? 2/3 of them with provocation also combined together. And definitely morphology will vary. What phenotype means? How the ventricle looks like, okay? As for example, this is like sigmoid shaped HCM. They are more common to have LVOT obstruction, very large asymmetric septal hypertrophy. Definitely they'll have more common to have LVOT obstruction. And reverse curve HCM, this whole septum is pretty big, and also the mid-cavitary area pretty big. They might have mid-cavitary obstruction. Apical variant of HCM, they're about 10%. Then you see that apical hypertrophic cardiomyopathy, they're more common to have apical aneurysm, and definitely sudden cardiac death is also prominent in this type of patients. And they have neutral variant, that septum is thickened, but all along, it's not like asymmetric here or mid portion or apical area. All along the septum is thickened, and they have some general LVH. So definitely, with all our current therapy and mortality, you could reduce the mortality below 1% at this time, even including implementation of ICD. So if you look at the micro level, definitely they have genetic mutation problem in the myosin heavy chain and myosin binding protein, and they have what in the end, they have a lot of cross-linking, cross-linking that causes significant hypertrophy and disarray of the myocardium formation, okay? And they have a lot of matrix tissue and causes fibrosis. And definitely, we talked about earlier, they have relative low blood supply in that area because according to the tissue mass, less coronary artery there, and they have relative, ischemia in that area, and they have fibrosis and they develop scar, and the scar can form re-entry mechanism and cause scar-related ventricular tachycardia or VFib. That's more common cause of sudden death in this type of patient. In macro level, as we know, once we have, as an example, like obstructive cardiomyopathy, septal hypertrophy, this is the outflow tract to the aorta. And as we know that when you have the septal hypertrophy, there's obstruction there. And then, as we know, the fluid particle hemodynamics, when blood flows through it, in the blood, we have particles like blood cells. When it flows through small narrow orifice, then it causes acceleration of the particle and causes a negative pressure at the bottom that sucks in the anteromytal leaflet to the wall, and I'm going to explain to you about that. That's one of the mechanisms of we call septal, anterior septal motion of the anteromytal, systolic anterior motion of the anteromytal leaflet. And definitely there's some structural abnormality and comes with functional abnormality with mitral regurgitation. And myocardial ischemia could be due to coronary insufficient blood flow to that area, increased metabolic demand, supply mismatch. This type of patient can have intermittent chest pain. Definitely, the ventricles are very thick. They have compliance issue. They have diastolic dysfunction. They develop scar, fibrotic tissue, decreased cavity size, and develop significant diastolic dysfunction in the long run. And we called it also scar-related ventricular arrhythmias. They're very common in these patients. Also common arrhythmia is atrial fibrillation. So let's look at that, how the fluid, particle dynamics happens. Just focus on this because here the blood going on, these are the particles, red cells. As for example, when you'll go through the narrow space, you'll see sudden acceleration of the particles goes very quickly, and that creates a vacuum here, and that creates a negative pressure here. Then normally mitral valve opens and closes. When it closes, and that's a systole part, but when this acceleration of the flow and negative pressure here, the mitral leaflet, anteromytal leaflet bends to the septum. That's what we're going to show you here to understand the mechanism. Here you see how quickly accelerates the particle. When it accelerates the particle, then it creates a vacuum here and causes a negative pressure here. And as you see that here, I'm going to show in a schematic way, and the ventricle starts systole, ejecting, and you see that fluid particle accelerates here, causes negative pressure here. The mitral valve, instead of closing normally in horizontal way, the anterior leaflet sucks in because of the negative pressure here. It sucks in and bends towards the septum, So ejection going on, and then it just almost touches the septum and causing obstruction. So eject, obstruct. And what happens when it bends towards the septum, there's a hole in the middle with the anterior leaflet and posterior leaflet that causes mitral regurgitation. That's one of the mechanism of mitral regurgitation in hypertrophic cardiomyopathy. And you see that it starts leaking. So eject, obstruct, and leak, they're the hallmarks of pathophysiology of obstructive cardiomyopathy. So here, as you see that, I'm going to play this video. And this is the, let's see. This is the diastole when the mitral valve is open, okay? And what happens in systole, look at that. In systole, this is a systole. And let's see. This is diastole and systole. And here you see the anterior mitral sucked into the ventricle, and that causes more obstruction. Sucked in, it should be in this way, but sucked into the other direction to the ventricle. When you see that, definitely you suspect the patient has LVOT obstruction. An important point to make for our trainee physicians, that this type of phenomenon will make you think about dynamic obstruction, because definitely you will hear the heart murmur. When you put a stethoscope on the chest, in the aortic area or LVOT area, you will hear systolic murmur in systole. You'll definitely hear it because there's obstruction going on, okay? There's obstruction going on due to the anterior motion of the systolic anterior motion of the anterior mitral leaflet towards the septum. So there'll be obstruction. You will hear the heart murmur. And that murmur is going to change with dynamic manipulation, okay, hemodynamic manipulation. How? Like, as for example, like anything you do that can decrease the ventricular size, mind it, anything you do that can decrease the ventricular size, that means LVOT is decreasing because the volume is decreasing, LVOT is decreasing in size, that will create the murmur louder. So as for example, anything you do that will cause preload reduction, like Valsalva, or like from lying condition to stand-up condition, you're decreasing the preload. So you're decreasing the volume of the ventricle and decreasing the size of the LVOT, that will have more obstruction, number one. So dynamic obstruction is inversely correlated with the preload. If the preload is low, for any reason, any manipulation you do, you will hear the murmur to go up. But another thing, contractility. Contractility. If you increase the contractility, your heart rate goes up, or increase the contractility, the murmur will get louder. As we call it, hypertrophic cardiomyopathy, obstructive cardiomyopathy is a diagnosis, a bedside diagnosis. So you should be able to diagnose on the bedside. You listen to the heart and aortic area or LVOT area. And if you hear a murmur, everybody, despite the aortic stenosis or any kind of systolic murmur here, ask them always to do the Valsalva, and you need to know how to do the Valsalva properly and hold that, and you'll see the murmur increases in size with Valsalva. You have already definitive diagnosis. All right. So I think somebody has to mute. I'm sorry, somebody has to mute. Hello, do you hear me? Okay, thank you. As you see,
এটা ফোনটা কারো ইয়েটা শোনা যাচ্ছে, মিউট করতে হবে সবাইকে।
somebody has to mute, okay? All right. Okay, now it's gone. Now we see, and if you put the Doppler probe, as I mentioned, always train the echo technician to do the Doppler probe from the apex and slowly go down. It could be mid-cavitary obstruction, it could be LVOT obstruction. When you see the obstruction, you will see this type of dagger-shaped, LVOT curve, okay, dagger-shaped. When you see the dagger shape, that means there's an obstruction there. And interestingly, you see another curve here. There's very nice dome-shaped curve of the velocity curve, and that is from mitral regurgitation. So the dagger shape you can differentiate, that's the LVOT velocity, and this is the mitral regurgitation curve. So you can differentiate these two from there. And if you do Valsalva on these patients, then if it is significant, dynamic obstruction, you'll see this one will jump to here. Next level will be here, 5 or 6, depending on that, how much bad it is, okay? So I'm going to skip that. Like few things that I need to make sure that you focus on that when you diagnose this patient, okay? First of all, your first step, you have to establish the diagnosis and also establish the phenotype. And also you need to differential diagnose at the same time, because you have to figure it out whether the patient has LVOT obstruction, resting, and whether it's provocable, whether they can provoke it, okay? And how much, whether they have basal septal hypertrophy, or look at that mitral valve apparatus, how the leaflet looks like, whether there's an elongated leaflet, whether that's causing any obstruction, how the papillary muscles lying, whether there's elongated papillary muscles or different placement of the papillary muscles, more apical spacing, whether that's causing the anterior mitral leaflet, moving to the septum, and how the papillary muscles look like, whether the thickened papillary muscles, bifid papillary muscles, whether those are causing problem. These are the things you need to do in the differential diagnosis, because that can also cause LVOT obstruction, okay? And definitely look at the diastolic function, whether the patient has apical hypertrophy, mid-cavitary hypertrophy, mid-cavitary obstruction. That your first level of diagnosis on those patients. And then once you establish the diagnosis, you need to risk stratify how much there is for sudden cardiac death. And if there's any suspicion for coronary artery disease, you need to define that with the patient has underlying coronary arteries, whether that's causing some symptoms to these patients. After you establish, then you need to do like possible genetic testing is available, and definitely family screening. So, and look at that, they might have different pattern. That's why the ECG is only, except for these two specific variants, is not very, we don't have any very specific, like 100% diagnostic variant per se, because ECG depends what is the LVH is, what is the hypertrophy is, okay? Like in this MRI view, we see significant hypertrophy in the lateral area in these patients, okay? Here we can see like diffuse hypertrophy down there. Here we see very much apical hypertrophy. And here we don't see much hypertrophy at all, okay, like normal distribution. So depending on what is the hypertrophy hit, you'll be surprised that MRI is showing us sometimes very localized hypertrophy. So you might see some changes on the EKG, 1 or 2 leads, but not like classic variant that we see in apical variant, or we see asymmetric septal hypertrophy, we see dagger-shaped Q wave in lateral leads, or sometimes in inferior leads. You might not see that in the ECG pattern. That's why MRI is sometimes helpful to localize what area the hypertrophy is, because that we might be missing in normal echo or just as ECG findings, definitely. And one thing that you have any suspicions, okay, and it's not very clearly visualized, the echo that we have, but if you have any suspicions, then apical area, normally we routinely do like contrast echocardiography, okay, because sometimes you'll be surprised that you can find like this type of patients when you do contrast, you see apical aneurysm, you can see that. Apical aneurysm. We could have missed it without the contrast. As you see in the MRI, you can see the apical aneurysm. Because very important to note that patients who have apical aneurysm, their event rate is 6.4% per year. They have significant risk of sudden cardiac death in this type of patients. That's why it's one of the criteria when patients have apical aneurysm, you know that both ESC guidelines and ACC, HA guidelines, if they have apical aneurysm, they would qualify for, ICD placement. And they have 3 times more greater risk with among the all HCM patients, patient who have aneurysm, they have 3 times greater risk of cardiac event. And look at that. We have some new data coming out recently, how we can incorporate artificial intelligence data, looking at the ECG, like we'll show, there's one example. This data came out from Cleveland Clinic. So I will show an example that this patient says, looks like pretty normal EKG, 60-year-old executive undergoing normal physical exam, but he has complaints. He has some dizziness. He, like with exercise, get out of breath easily, but ECG doesn't show much, pretty normal looking ECG. But interesting enough, in this institution, in Cleveland Clinic, they trained the artificial intelligence machine learning system with 85,000 ECGs. And in the main campus, they did 42,000 ECGs. They analyzed those data. They interestingly find that machine learning with artificial intelligence, they flagged 1,200 patients. That was, they flagged that artificial, intelligence. They flagged that 1,200 patients might have HCM. And interestingly, 50 of them were newly diagnosed, which was not diagnosed with normal modalities. 50 of them, the ECG did that. And in this particular patients, ECG, artificial intelligence, they flagged that the patient might have HCM. He underwent further testing with echo and provocative testing, and definitely we see the Valsalva, this dagger-shaped LVOT, velocity, it increased with Valsalva. So definitely the patient had obstructive hypertrophic cardiomyopathy. That would have explained why the patient has, dyspnea on exertion and occasional dizziness, despite that EKG might be looking normal. So here's important point I'm going to make. In the future, artificial intelligence and analyzing the ECG will have more role in diagnosis this type of undiagnosed patients, because so much nuance of that. And not only ECG, now we are getting more data when incorporating not only the ECG data and also echocardiogram data. And that gives a more robust, diagnostic tool in the future. And interestingly, I'll show you another data set that came from Yale University and Mount Sinai. They analyzed 290,000 echoes in the machine learning system to train the system with AI system. And they analyzed also the point of care ultrasound they did in the ED, those patients, 90,000 patients with POCUS, okay, point of care ultrasound. And interestingly, what they found that this artificial intelligence system, if you apply that, and they had longitudinal data over the several years, they found out that they flagged 58% of the patients with confirmed HCM, they diagnosed them earlier, 2.1 years earlier, which ultimately they were confirmed. Because another point I'm making with this data set, that artificial intelligence can diagnose some of the hypertrophic cardiomyopathy cases 2 years earlier before a clinical diagnosis could be made. So that's a huge improvement in that as a diagnostic tool for us. So here's the role of ECG, not only ECG, now we're getting more data from Yale University and Mount Sinai system that incorporating that echocardiogram data, point of focus ultrasound in the ED, we can diagnose a lot of cases of the hypertrophic cardiomyopathy, which are clinically confirmed later on, 2.1 years earlier. Definitely, you can risk modify those patients, you can treat them earlier, you can significantly modify their outcome. So, point number 2. So, whenever you do any study, always think about that if you don't see significant LVOT obstruction, as for example in this study, always do some provocating test. Either with Valsalva, that could be done as bedside when the echocardiogram technician does that. Always train them how to do Valsalva. It's very important to do. If you see suspicious acceleration of flow here, you do Valsalva. Okay, and you see that LVOT velocity 1.5 with Valsalva you went to 5.2 meter per second. That's a significant change. So you can elicit some LVOT obstruction with some provocative measures. Valsalva you can do exercise treadmill test, you can do bike exercise test, you can do amyl nitrate test. Any way you can elicit and provoke that, you should do it, because sometimes 30% of them you can miss without doing provocation. And as the data from Cleveland Clinic, Dr. Desai's group is one of the pioneer in studying hypertrophic cardiomyopathy, and he did a lot of trials with the cardiac myosin inhibitors. Dr. Desai has huge database in Cleveland Clinic. And they showed that if the patient has exercise capacity is less, they have higher mortality rate in this type of patients. Okay, and interestingly enough, those patients with obstructive cardiomyopathy who had myectomy, definitely they did better. But who did not have myectomy, we know that their prognosis is worse because of the significant obstruction and ongoing continuation of the symptoms and complications from that. So bottom line had designating someone with non-obstructive cardiomyopathy without provocation is not appropriate. So you just cannot tell them that you don't have non-obstructive cardiomyopathy if you did not do the provocation test. That's a very important point I'm making. If you don't look, you cannot find, you cannot treat those patients. Look at that. Point number 3. So a few things I need to let you know, like this is the normal variant, okay? So here are papillary muscles. We call it posteromedial papillary muscles or anterolateral. In the posteromedial papillary muscles, they give chordae to anterior leaflet and posterior leaflet. Both leaflets, they give chordae. If this papillary muscle is displaced to the apical area, then what's going to happen with systole? This anterior leaflet can go down to the septal area, like this way, go down to the septal area in systole. That can cause similar phenomenon with obstruction, LVOT obstruction. But that is not due to hypertrophic cardiomyopathy. That is due to abnormal papillary muscle, more apically displaced papillary muscles. But you will have the similar symptoms of dyspnea on exertion and may have similar worse outcome in these patients as we have obstructive cardiomyopathy. Like as for example, if they have abnormal chordal attachment, okay, elongated chordae, they can have similar with systole bending of the anterior leaflet to the septum. They might have similar obstructive pathology, okay? So, but that is not due to hypertrophy. Don't miss that. I have several patients we found out on echocardiogram. We see that elongated chordae and having obstruction, but they don't have hypertrophy. They're not like typical hypertrophic cardiomyopathy patients, but they have similar symptoms with obstructive cardiomyopathy. Don't miss that. Okay, as for example, like it's normal papillary muscles. Okay, there is a thickened papillary bifid papillary muscle. When they thicken papillary muscles, they might have similar. When they squeeze in systole, they might have mid-cavitary obstruction. Mid-cavitary obstruction might have similar pathology of obstructive cardiomyopathy. So when you examine the patient, bottom line here, so you need to look at the valve, subvalvular, papillary muscle pathology. If you see any acceleration of flow, and if you see any increase in either mid-cavitary obstruction or outflow tract obstruction, because that you cannot do myectomy for these patients, but this patient needs to be referred to hypertrophic cardiomyopathy centers, and surgeons need to be very creative how to fix these papillary muscles or maybe repair of the chordae, if it's elongated chordae, to fix their problem, because it can significantly modify their long-term outcome. So designated someone as not being having cardiomyopathy based on lack of LVH is not appropriate. As for example, they have obstruction, but they don't have LVH, and you're telling them, no, you don't have hypertrophic cardiomyopathy. Yeah, they might not have true hypertrophic cardiomyopathy, but they have obstructive physiology due to other causes like papillary muscle problem, elongated chordae, or apically displaced papillary muscles that causes the anterior mitral leaflet to fall back to the septum during systole, because you need to treat them and you need to have a good skilled surgeon to help them so that they can somehow repair or do surgical repair on these type of patients that can significantly improve their quality of life and survival. So a few things, as I mentioned to you, this is the findings that we have, like elongated, I'm just emphasizing the case, anterior mitral leaflet elongated, okay? So this type of patients have like obstruction of flow, we can see that, okay? Obstruction of flow. And you see here, bifid, hypermobile anterolateral papillary muscles here, and we can see that obstruction in flow in echo. And we can see that, significant obstruction in flow. Here we have abnormal chordal detachment, just very long elongated chordae, and there's attachment there that can also cause some LVOT obstruction. You can see the LVOT velocity is increased. So you don't want to miss that. Always look at, mitral valve structure, subchordal structure, papillary muscles, how they sitting there, whether it's misplaced, whether they thicken, whether different morphology there, that can also cause obstructive cardiomyopathy features. And definitely, myectomy will not work. And definitely this patient is not a candidate for cardiac myosin inhibitor, the new kind of treatment, because they don't have truly hypertrophic cardiomyopathy. This obstruction is due to subvalvular underlying apparatus problem. The important is that, as we see that strain analysis, this is like asymmetric septal hypertrophy variant. We see that septal area definitely, we see this is the asymmetric septal variant that we see in strain analysis. When you get a polar map together smashed, then you can get a polar map of that. This is, we see the apical variant when the apex is involved. Here we know that apical sparing, that's very diagnostic of amyloidosis. All right, this is LVH due to aortic stenosis or hypertrophic, or hypertensive heart disease could be similar like that. The reason is important to diagnose that and also do the cardiac imaging modality like MRI. You can diagnose like glycogen storage disease, Fabry's disease, athletic heart, amyloidosis. You need to really follow up on these patients, because most important point I like to make, because in apical hypertrophic cardiomyopathy, you do not want to treat this patient as amyloid with tafamidis. And with amyloidosis patient, you do not want to treat this patient with cardiac myosin inhibitor. Absolutely not. So you need to have a very good differential diagnosis in mind, and in order to direct your treatment to the right direction. So one important slide I'd like to make, despite this highly trained center like Cleveland Clinic, this is data from Cleveland Clinic, they studied 2,472 patients who already had myectomy, surgical myectomy in the Cleveland Clinic, on the renowned clinic. They found out that when they did that post-surgical tissue analysis, they took a sample of that. 1 in 5, they did not have hypertrophic cardiomyopathy. They had alternative diagnosis. This is surprising. Okay, so this is like more like hypertrophic cardiomyopathy. You see that myofibrils in different direction is going on in hypertrophy, different direction. It's not straight. Normally you see pretty much linear fashion, but they are very haphazard patient. This is like characteristic of hypertrophic cardiomyopathy. These patients just have hypertrophy, but linear fashion is hypertensive heart. And this is Fabry's disease. This is cardiac amyloid. This is amyloid deposition. And this characteristic of myocarditis. So interesting enough, even in the very trained clinic, okay, 1 in 5 did not have hypertrophic cardiomyopathy, despite that they went for myectomy surgery. So few slides for the trainees. Like in the patient with known diagnosis of hypertrophic cardiomyopathy, they are acutely sick. Like in the patients in ICU, patient septic or something going on. Okay, definitely what you need to do when the blood pressure is dropping, tachycardic, definitely you need to give fluid first. But what you need to do, be cautious. Be cautious. Even the patient might be a little bit overloaded with fluid. Cautious to give aggressive diuresis. Do not give aggressive diuresis. Okay. But definitely, you need to make sure they're very intolerant to tachycardia. If the heart rate is too fast, they are intolerant in hypertrophic cardiomyopathy patient. You know that they will have more obstruction, cardiac output is going to drop further, and blood pressure is going to drop further. So control of arrhythmia is extremely important. Slow down the heart rate. Slow down the heart rate. The patient, if there's emergency, you can do in cardiovert the patient. It's important to slow down the heart rate. And sometimes we can use a smaller drip. But before you use that, if the patient is like really low blood pressure, you try not to do any inotropic. That's the bottom line. No dopamine, no milrinone, no norepinephrine or epinephrine. You need to use pure vasopressor. Drug of choice is phenylephrine. Drug of choice is phenylephrine. Okay, and definitely avoid any vasodilatory agents in this type of patients. Okay, like it's opposite to like mitral regurgitation or acute mitral papillary muscle rupture. You do vasodilatory as much as possible. In this type of patients, they can decrease the preload and make it worse. You can do pure vasopressor in these patients, and pure vasopressor is phenylephrine that works in the vasculature, not much on the cardiac contractility. In chronic patients, what you do, and definitely first thing, and according to the guidelines that we have, both ESC and ACC HA guidelines, definitely need to review that. First, lifestyle modification, right? They need to avoid dehydration because we need to make sure the ventricle not smaller, because if your dehydrated preload is low, it will cause more obstruction. They need to drink plenty of fluid and avoid dehydration. They're okay to participate in moderate intensity activity, and I'm going to show the data why, okay? And definitely, if the patient is symptomatic, they need to be cautious and also have to have shared decision-making whether they can participate in highly competitive sports or strenuous exercise activity, because you have to make sure what the symptoms are, and they have to also risk stratify them with certain cardiac risk before you can allow them to do some sort of activity. That's also should be done with shared decision making. But if they're genotype positive but phenotype negative, that means they don't have significant hypertrophy, any pattern, no symptoms, they're okay to participate in competitive sports. But you need to have longitudinal follow-up on these patients. Every year you need to do ECG, echo, and sometimes necessary to other cardiac imaging modality like MRI. And important points comes along when if the patient is a pilot, truck driver, high risk, profession, what you need to do. Make sure they're asymptomatic, and also look at the SCD risk, certain cardiac death risk. If they're low risk, and you probably can allow them to continue their activity in this profession, but also you need to communicate. Here in the United States, we have to communicate to the state's licensing board if there's a pilot that, yes, the patient is under observation, patient is asymptomatic, and the certain cardiac death risk is low, they can continue that profession, okay? So there's very important data came out about the exercise activity. There's a multi-center study of vigorous exercise in patients with hypertrophic cardiomyopathy. We call LEAVE HCM trial, Dr. Lampert's group. And what it shows they studied like 1,660 patients with HCM, phenotype positive, genotype positive, phenotype negative. They have different combination, but the New York Heart Association classification was 1 to 2 symptoms. They had followed these patients 3 years and self-reported exercise activities. And one group is less than 4 minutes, another group 4 to 6 minutes, another group higher exercise 6 minutes. And interesting, their combined endpoint composite certain cardiac death, ICD shock, arrhythmia, cardiac syncope, they took as study endpoint. And if you distribute them, that 15% were them sedentary, 43% did moderate exercise, and 42% they did vigorous exercise. And when the data came out, very interesting that people who are sedentary lifestyle, not much exercising at all, they have the higher event rate, 6%. They're statistically significant compared to 4.6% in moderate exercise group and 4.7% in vigorous exercise group. After the data came out, and we we are allowing these patients to do some aerobic exercise, moderate amount, that's safe for these patients. And if the patient is symptomatic, then make sure they get well hydrated, they follow the rules of hydration, and make sure avoid intense isometric exercise like muscle training exercise. Those type of weightlifting and those type of exercise is not recommended for them. But normal walking, aerobic exercise is recommended for this group of patients with the data, the live HCM trial that came out. So what are the things we need to look at in hypertrophic cardiomyopathy patients? Definitely, we need to look at also risk of sudden cardiac death in these patients, because 1% annual incidence before the ICD was implemented, okay? But most commonly, people die with VFib because of this scar-related, tachyarrhythmias that you talked about, cause re-entry within the myocardium. And with ICD use, we get it, definitely we could get 50% reduction, less than 0.5% annually. And interestingly enough, that when you analyze about age-related incidence of sudden cardiac death, we see that above 60 years of age, we see less evidence of this sudden cardiac death event. There's a question about how real it is, okay? Maybe people who had sudden cardiac death might have happened even earlier, so they didn't reach that stage. So it's still not very clear, why we see that phenomenon. And definitely another important thing for our trainees, because this type of patient, we call burnout hypertrophic cardiomyopathy. If their symptoms persist, they ultimately get to systolic failure. Okay, definitely they have diastolic dysfunction, but they ultimately go to systolic failure. We call it burnout heart failure. But as we know, that in normal, cardiomyopathy patients like ischemic cardiomyopathy or dilated cardiomyopathy, non-ischemic, 35% of EF is cutoff point to put a defibrillator. In these hypertrophic cardiomyopathy patients, normally to begin with, they're hyperdynamic. Their heart even like 70%, 75% hyperdynamic. If they fall below 50%, that means they're severely depressed, that you consider. And this type of patients, according to current guidelines, they will qualify for a cardiac, CRT device. Okay, and definitely we should continue using guideline-directed medical therapy as we use for heart failure patients. And this type of patients might end up with heart transplant therapy in the long run if they get progressively worse. Another important point I like to make is atrial fibrillation, because as you know, hypertrophic cardiomyopathy patients, if they're obstructive particularly, they do not tolerate tachycardia. So you need to be very aggressive treating their tachyarrhythmias. If the patients, and 25% of the patient will have AFib. So if they have AFib, you need to be very aggressive. First of all, quickly cardioverse if possible. And also you might need to more definitive treatment, but this type of patients we really encourage to do ablation, because the first line therapy you're considering right now ablation rather than medical management. And another important point I like to make, that would be board question for the trainee physicians. Any hypertrophic cardiomyopathic patients, if they have AFib, proximal AFib, or permanent AFib, you need to, first of all, need to bring them to normal rhythm if possible with a cardioversion ablation. If not, they will stay there, you control the rate. But everybody will need anticoagulation because they're higher risk of stroke. Do not use CHA2DS2-VASc score for them. It doesn't apply to them. Very important point. They might have CHA2DS2-VASc score 0, but normally they don't. But if they have 0 score, still they will not, everybody will need anticoagulation, okay? All right, let's then step 4, how we're going to risk stratify for sudden cardiac death in these patients, okay? There's 2 different, criteria we follow in European Heart Association criteria. They take age, maximal wall thickness, left atrial size, LVOT gradient, family history of sudden cardiac death, non-sustained VT, syncope. And they have a calculator there. You can Google it. You can find that calculator. You put this information. And if it is score is like less than 4%, then ICD is not indicated by ESC criteria. If it is more than 6%, they will require ICD implantation. 4.6% may be indicated, and that's a shared decision making with the patient, discuss with that. Some people will get it, but it's a shared decision making process in that group. But with American Heart Association ACC criteria, similar, almost similar characteristics. We have family history of sudden cardiac death in the first degree relative, and less than 50 years of age. If they have it, they should get it. If LVH more than 30 millimeter, they should get it. But 28 to 29 millimeter individual discretion, look at the risk they've involved, symptoms they've involved, shared decision making, you may choose to put it, okay? If it's unexplained syncope in the patient, not like in the family member, in the patient, unexplained syncope, so that it's not orthostatic, not vasovagal, they will qualify for, defibrillator. If they have non-sustained VT, 3 or more brief episodes of non-sustained VT, or at least 10 beats, more than 130 beats per second, they will qualify for ICD plantation. And importantly, another late gadolinium enhancement on the MRI. If they have more than 15% late gadolinium enhancement of the full LV mass, they will qualify. Why it's important? What does it do, gadolinium? You know that when you give the gadolinium contrast, it accumulates in the matrix area, extracellular space. That's the area we see fibrotic tissue. So that if there's a more accumulation of the late gadolinium enhancement in that area, in the extracellular space, and that means they have more fibrous tissue, more nidus for scar, and more nidus for arrhythmia. Okay, they can create a scar-related reentry mechanism for ventricular fibrillation. That's why it's very important to follow that parameter also. And if the patient has end-stage hypertrophic cardiomyopathy, as we mentioned about, the point is here for the board question is 50%, less than 50% LVEF. They should qualify for SCD and CRT device, okay? And if they have LV apical aneurysm, as I mentioned to you, they have 6.4% chance of sudden cardiac death. They're higher, 3 times higher than other group of hypertrophic cardiomyopathy of sudden cardiac death. So apical aneurysm, they will qualify for ICD placement. That's important. This data, any of the form, it will come on your board question in the cardiology board. So how you manage those patients? The step 5, definitely lifestyle modification. We need to make sure that they have adequate hydration. Our main goal to control symptoms, and then we do medical treatment with beta blocker, calcium channel blocker, and on occasion disopyramide. And also some new medications we'll talk about, like myosin inhibitors, like mavacamten or aficamten. But definitely we need to make sure if they're symptomatic and LVOT obstruction, we ask them to avoid competitive sports, but we do allow aerobic exercise, moderate intensity. Definitely they need to avoid volume depletion, dehydration I mentioned above. They need to avoid isometric muscle strain exercise. They need to avoid vasodilatory therapy. They need to avoid inotropic agents like digoxin-like medication. Definitely need to assess their sudden cardiac death risk assessment. Then we need to screen those patients by serial ECG, echo, yearly basis, and also genetic testing. In first degree relative also need to do that. So another important point, if the patient has non-obstructive cardiomyopathy, definitely, we can use first-line beta blocker and non-dehydropyridine calcium channel antagonist. But, if they have no symptoms, normally you do not start. If they have symptoms, sometimes the symptom improvement can happen. But definitely, myosin inhibitors, the data shows by recent trials, not beneficial in this type of patients. We don't use that yet, okay? And definitely we need to be very cautious with diuresis in the patients. If the patient having, systolic dysfunction, some volume retention, you can use some diuretics, but you have to be very careful about not to make them dehydrated. And a major problem with this, general treatment on these patients that they will complain of, like low heart rate, bradycardia, fatigue, erectile dysfunction, QT prolongation, anticholinergic effect. Note that, when you treat those patients, to discuss with this patient whether they have any side effects with the medications. So, and we know that definitive treatment in particularly obstructive cardiomyopathy with asymmetric septal hypertrophy, definitely, reduction of the myocardium in that area, we call septal reduction therapy. The more definitive treatment and the best treatment still we do is surgical myectomy, definitely alcohol septal ablation is possible. We'll discuss that. And newly developed like sesame technique, we like transcatheter approach going to the aorta and take some myocardium out from the septal hypertrophy area. So here, as we see that when we do myectomy is straightforward. You go through the aorta and shovel out the asymmetric septal hypertrophy area, and that way they improve LVOT obstruction clinically, they improve. And interestingly, when they do myectomy, their mortality rate is very low, and they're pretty close in 5 years mortality to the normal population. And in the septal, when you do alcohol septal ablation, we go to the coronary artery and go to the septal branch that's supplying the septum. And you see there's a balloon there. We protect the artery with the balloon, and then distally we inject alcohol. Alcohol is a toxin agent here with the myocardium. They basically make the tissue dead, okay, bottom line. So we do that, and we see sometimes immediate reduction of LVOT gradient, okay? But interestingly enough, the data shows that 1 in 10 patients, they with alcohol septal ablation will require repeat procedure, okay, compared to like 1 in 25 with myectomy. So definitely repeat procedure is much higher with alcohol septal ablation, and enough information that I'd like to give that these patients would require, like more pacemaker, okay? That's important. And another important thing that I like to make it to be board question, that if the patient goes to septal myectomy, surgical reduction of the myocardium, if the patient has left bundle branch block, then they will require pacemaker. Make sure you know that. This left bundle branch block is the septal area that you're taking out. Sorry, excuse me, I'm taking it back. I said it wrong. If the patient has right bundle branch block and you do septal myectomy, then you'll make it left bundle branch also go away. Then they will need a pacemaker. So in surgical myectomy, if the patient has right bundle branch block, then you will destroy the left bundle. The patient will need a pacemaker, okay? But in alcohol septal ablation, the opposite way, okay? If the patient has, left bundle branch block, then alcohol septal ablation most commonly causes right bundle branch block, and there are higher chance of getting a pacemaker. But this is the transcatheter technique we call sesame technique. Basically, we go with the catheter with some small catheter, sharp needle. We go down there, try to go through the muscle and basically take it out with the catheter, and their LVOT gradient significantly drops. So few data on cardiac myosin inhibitor. So it was approved, mavacamten approved in April of 2022, and aficamten approved in December of 2025. And basically what it does, it causes like phosphate release. It blocks the phosphate release from the, actin myosin complex, and that causes the decrease in cross bridging, and that decreases the hypertrophy and obstruction. And as you see the data from Explorer trial, mavacamten improved their oxygen consumption, PVO2 compared to the placebo. And also important point to make that 5.7% of patients mavacamten, they had transient drop in EF less than 50%, but they're all reversible, and after cutting down the dose, they become normal. And there's another data with aficamten, SEQUOIA trial in obstructive cardiomyopathy had similar results. They improved the PVO2 consumption, oxygen consumption, but they had less 3.5% of transient reduction, LVEF less than 50%. But we do not have good data on in non-obstructive cardiomyopathy. Actually didn't improve PVO2. It had modest improvement on biomarkers. That's the reason we are not using any cardiac myosin inhibitors right now with non-obstructive cardiomyopathy. So what's the future of hypertrophic cardiomyopathy? Definitely the artificial intelligence, including the ECG and transthoracic echo, will be helping us tremendously, and we are expecting more help in the early diagnosis of these patients. And definitely cardiac myosin inhibitor, we're expecting like first-line medical management could be there. And also another thing that we're looking at, that if we know that if we start cardiac myosin inhibitors, we can decrease the number of patients who might require surgical treatment or septal reduction therapy. So CMI in obstructive disease is very promising, but only problem is that it's extremely expensive. It's very expensive treatment. I'm not sure how we're going to do it in other countries. All right. But new in the horizon that we have, other mitotropic agents, they're extremely studied right now. They affect the cardiac metabolism. Sorry, can you mute?
Atahar bhai mute koren. Atahar bhai please mute koren.
And there is some decrease in myocardial consumption. They work on that. And also very promising therapy, we're working on that. That's called gene therapy, okay? There's already testing adenoviral vector for MYBPC3 gene, and we're getting some promising data. Very, very few studies going on. And MyPeak-1 trial is ongoing still in heart assistant classification 2 to 3 that affects the MYBPC3 mutation gene. And we're using CRISPR technology to just modify the gene. And I'm expecting in the future, probably gene therapy will be predominant in the treatment of hypertrophic cardiomyopathy patient. If we can identify the gene, we can modify the gene with the gene therapy, we might be able to potentially cure this patient in the future. But there's a hope, and we might not get the benefit in the future ourselves. All right, let's have a case, and I need to polling on that. These cases are for the trainees. Please answer those as much as possible. It will come on your board. Which of the following is the indication of an ICD in a patient with HCM? Septal wall thickness 26 millimeter, late gadolinium enhancement on cardiac MRI 10%, unexplained syncope in the first degree relative, and LVF of 45%. Just give a poll. Can you give it a poll? Please answer those. I'd like to everybody answer because I already explained that I need very good answer on that. And particularly I focused a few times on these parameters. Please vote.
Keep the poll open for the update.
All right. What I see here, I see there's a split vote, C and D. As I mentioned, let me tell you, D is correct. As I mentioned, that hypertrophic cardiomyopathy patients, we call it significant LV ejection fraction drop is below 50%. They need CRT device, okay, or defibrillator, because their event rate is higher. Because normally hypertrophic cardiomyopathy patients, they're hyperdynamic. Their LV function in normal conditions 70-75%. There's on the higher level. So when they drop 50% or below, we call it pretty much going to the end-stage cardiomyopathy pattern because they're dropping the myocardium, they're dropping the reserve. So this type of patients, 50% or less, okay, they will need an ICD. So that's the diagnosis. But here, a lot of people answered C. But look at that. What's the question here? Unexplained syncope in first degree relative. No. It has to be in the patient, unexplained syncope. The patient himself has unexplained syncope, not first degree relative. First degree relative, if they have sudden cardiac death, then the patient will qualify if the first degree relative had sudden cardiac death. And definitely septal wall thickness should be 30 millimeter. LGE should be 15% of the total myocardium. So it's a board question. Make sure don't miss it. Okay, let's do another case. A 54-year-old male with hypertrophic cardiomyopathy with LV-OT gradient of 70 millimeter mercury, currently on metoprolol. Patient is febrile, tachycardic, hypotensive, basically in septic shock right now. He was given already 2-liter fluid. Patient is in the ICU. What would be your next step, except of giving, workup, blood analysis, blood culture, broad spectrum antibiotic? With the patient's blood pressure 80/50, whether you need to start dobutamine on this patient, when you start norepinephrine on this patient, when you need to start esmolol drip on this patient, or initiate phenylephrine. Let's get a poll. Please answer. This is a board question for you.
keep the poll open for 20 seconds.
Very good. At least I believe I have some success in giving that lecture. Okay. Yes, you need to use pure vasopressor. Do not use any inotropic agents because you're going to increase in contractility. As you know that if you have obstructive cardiomyopathy, if you increase the contractility, then it causes more obstruction. Their cardiac output is going to drop. And if you start him on dobutamine or norepinephrine or epinephrine, the blood pressure is going to drop further. So his cardiac output is it will create more obstruction and less cardiac output, blood pressure drop. You'll just basically crush the patient. Yes, answer is phenylephrine. It is mainly peripheral vasopressor on alpha receptor, okay? All right, let's do one more case and we'll be done. A 20-year-old female college athlete presents to you after her brother was diagnosed of obstructive hypertrophic cardiomyopathy, not herself, her brother, and was found to have pathogenic mutation on genetic testing. The brother had gene mutation positive. She's asymptomatic, but is found to have some pathogenic mutation so she's asymptomatic, but she's also gene positive. Okay, what recommendation would you have regarding exercise? Because she's an athlete, she wants to do exercise. So do you want to put an ICD and approve for participation in sports? No additional competitive sports if found to be phenotype positive. So basically, you just prohibit her from doing so many competitive sports, or you want to say okay to resume competitive sports if phenotype is negative. Please answer. Let's have a poll.
Again, keep the poll open for 20 seconds and then close the poll.
These are very practical questions they will ask you. All right, majority of them, at least 50% did the right answer. Yes, okay to resume competitive sports. The reason is we are very nervous, telling them whether you can do competitive sports. Because when we're going to prohibit them, despite their genotype negative, but they're asymptomatic and phenotype negative, means they don't have significant hypertrophy yet. They're positive with the gene, but they did not have asymmetric septal hypertrophy, no LVT obstruction, no symptoms. I think they can still participate in competitive sports, and you have shared decision making with these patients and to have close follow-up yearly basis, and ECG, echo, and in the future may need cardiac MRI. Because this type of patient, 25% patient will convert to symptomatic HCM. Then you can prohibit them to competitive sports. But currently, let her enjoy the sports that she likes. I'll stop here, and if any questions, I'd be happy to answer. Tushar, you can take it over.
Thank you very much, sir. You have covered a very critical subject and explained the pathophysiology, ECG findings, echo, and cardiac MRI things in a very understandable manner. Thank you very much from ECG study group. Before adding something more, I want to ask Professor Abdul Chowdhury sir to say about the presentation and his thought on hypertrophic cardiomyopathy, ECG changes, and other things, and how trainee doctors should approach in a patient with hypertrophic cardiomyopathy. Wadud sir.
Azif bhai, joy hoque apnar. Thank you for a beautiful presentation. I have covered some very important topics. One of them is, despite the ECG changes, when someone is doing the echo, they do not look out for the apical HCM and they miss it. And before doing any echo, you should have a look at the ECG. And if necessary, please auscultate. And then you will not miss that much. Number one. Number two, you can find out some patients who have almost near normal ECGs, but echo finding of hypertrophic cardiomyopathy. Always remember that. Number 3, as he has mentioned, when the ejection fraction is going down, be careful. These patients are very bad patients. And if it is below 40%, they should be put on an ICD, preferably. That's the point that he has mentioned. And some of them are actually transplant candidate. Number 4, the newer drug, the mavacamten, in hypertrophic cardiomyopathy, the relief it gives the patient, because I have seen so many patients, the relief it gives is really tremendous. And surprisingly, we are using off-label some of the obstructive, non-obstructive cardiomyopathy. When they complain that they have symptoms whenever they are going upstairs, that means whenever they're putting on exertional load on the heart, they're having the symptom. Some of these patients, whenever given mavacamten, though it is not yet given green light, they have very good symptomatic relief.
And I want to ask a question. How much cost there? Because here it's extremely expensive, this medication.
আমাদের দেশে অনেক কম খরচ।
Okay,
মানে
at least
patient
people can
afford
enjoy
করতে
it.
পারে।
That's great. Yeah.
পেশেন্ট এতে অ্যাফোর্ড করতে পারে এবং এটা পেশেন্টের রিলিফটা দেখার মতো। And surprisingly, another thing is that, and after 6 months, many of the patient has at least 2 to 4 millimeter of regression of muscle thickness. And that's remarkable. And I have stopped 2 patients mavacamten because their obstruction is totally gone and their ejection fraction is going down, so I have to stop it. Then it goes back to normal, but I'm watching out for the wall thickness. Whether it is
And actually, there's new data on that, Dr. Wadud. When they drop the EF, you can temporarily hold, but there's a data, sub-analysis data, sub-Hoque analysis on those Valor study and Explorer study. So you can start low dose mavacamten, and they do tolerate well, and ejection fraction maintains, it doesn't drop further. At least 2 years we have data.
Actually, I actually do that. Stop it, watch it. When it comes to the basal 55%, then I start it at a lower dose and maintain it. I have done that for 2 patients, and 2 patients I have to stop altogether because it's going down.
That's possible, yeah.
And another thing is that we are not using ICD, despite it's being strongly indicated in many of these patients. I have had families where brothers and sisters all have ICD because they have hypertrophic cardiomyopathy with wall thickness going around 30 or more than 30, and family history of SCD, multiple time patients, and 2-3 generation জুড়ে এরকম আছে। তাদের ক্ষেত্রে ভাই বোন সবাই তারা ই করতে পারে, তারা কিন্তু লাগিয়েছে এবং তারা ভালো আছে। এবং তাদের মাঝে মাঝে দেখা যায় যে নন এসভিটি হয় এবং সেটা টেকিকার্ডিয়া, অ্যান্টি টেকিকার্ডিয়া পেসিং করে সামলাচ্ছে, ডাটা অ্যানালাইসিস করলে আইসিডি, সেটাও দেখা যাচ্ছে। এই জিনিসগুলো আমাদের সেটা খেয়াল করা উচিত এবং তাদেরকে ওই যেটা আপনি বলছিলেন যে এখন কিন্তু বারবার বলছে যে অ্যারোবিক এক্সারসাইজে নিষেধ করার কোনো মানে নেই।
That is correct.
কিন্তু আমি যেটা বলি, আমি বলি ভারী জিনিস তুলবেন না, টানবেন না, ধাক্কা দিবেন না, বহন করবেন না।
That's isometric exercise.
Isometric exercise. তার মানে আপনি বাচ্চাকে নিয়ে বাচ্চাকে কোলে নিয়ে আপনি সিঁড়ি বেয়ে উঠবেন না, আপনি ভারী একটা ব্যাগ টেনে আনবেন না, আপনি 10 কেজি 5 কেজি 7 কেজি আপনি করেন, কিন্তু এর থেকে বেশি ওজনে কিছু বাজারে ব্যাগ নিয়ে হাঁটবেন না। মানে খুব সিম্পল, যেটা তার লাইফে কাজে করে সেই জিনিসগুলা। কিন্তু আপনি ইচ্ছা মতো হাঁটেন, সকালে জোরে জোরে হাঁটেন, কিছু হবে না। তাদেরকে এভাবে এনকারেজ করি। এই জিনিসগুলো আমাদের যারা ইয়াংস্টার আছে তাদেরও এটা খুব খেয়াল করা উচিত, কারণ এই পেশেন্ট গুলার symptomatic কি পরিমাণ হয়। I have seen that family life, young married couple having a very difficult conjugal life because of the level of symptoms he has whenever he is going for intercourse. So, and that patient, when they are given mavacamten, the relief they got is really satisfying.
And I like to take one case that we have a patient that all along he was diagnosed with asthma, and they're getting treatment for asthma. Okay. And interesting enough, we looked at the echo, we did provocative test. She had obstruction. Okay. Put on mevacampton. And few months later, doctor, you cured my asthma. She doesn't understand hypertrophic cardiomyopathy, but she feels much better with asthma attacks.
মানে এই জিনিসগুলো আসলে যে একটু পেশেন্টটাকে ইসিজিটা একটু ভালো করে দেখা, পেশেন্টটাকে একটু ভালো করে অস্কালটেট করা এবং ইকো করার সময় খুব সাবধানে করা, তাহলে কিন্তু বিশেষ করে এপিক্যাল হাইপারট্রফিক কার্ডিওপ্যাথি আমরা মিস করি। আর আপনি আরেকটা যেটা বলছেন এপিক্যাল অ্যানিউরিজমটা মিস করা হয়, এটা কিন্তু ভালো করে না দেখলে আসলে বোঝা যায় না। কিন্তু ওই যে আপনি আজকে যে ইনফরমেশনটা দিলেন যে এমআরআই করে যে দেখার বা কন্ট্রাস্টের, এটা কিন্তু আগে আসলে খেয়াল করি নাই, যে এখন একটা এটাও খেয়াল করতে হবে, আমাকে ইনস্ট্রাকশন দিতে হবে, ভাই এটা কন্ট্রাস্ট দিয়ে করো, তাহলে সন্দেহ করলে ওটা দেখা হচ্ছে। থ্যাংক ইউ আজিজ ভাই, ইট ওয়াজ এ বিউটিফুল লেকচার, ভেরি ইউজফুল লেকচার, and I think old veterans like us and also the young doctors, all of us are greatly benefited by your lecture, and we enjoyed it thoroughly.
Thank you. A little bit prolonged, but I had to cover a lot of stuff. All right.
Yeah.
Thank you.
Thank you all participants, and we'll again meet on the 28th June, and this will be a special lecture. Emnozul Islam sir, former director of NICVD, and we'll let the topic known to all of you by 26th June. Again, we'll meet at that time.
All right. Thank you. All right. Then I can leave. Thank you.